Hey folks, Kevin here. Well, it's March 1st, 2022, and today's video is going to be about our taking responsibility for our own health and well-being as well as those of our loved ones and people we care about. Thea and I have posted a video recently about the 10 forms of capital or investment or wealth that we invest in. And one of the most important things we can invest in is our own personal health and well-being. And I posted videos in the past about the nutrition and exercise, those sorts of things, lifestyle medicine. I posted a video about 4 years ago, which part of that video will be included in this video because I think it's so important, and that was the leading causes of death in the United States. And we've mentioned that we've had our own medical challenges in life, and we're taking every step that we can take to reduce the amount of pain and suffering and costs as well that we may endure as we get older. As far as the leading causes of death in the United States, I haven't updated the data. That'll be presented in this video, and it'll be towards the very end of the video that you're going to see, where I explain the stats taken from back to 2012 data from those periods, and there are references. There are links in each one of the videos that you can go to see for yourself the actual data. I haven't pulled up recent data because of the pandemic and because of changes based on government requirements for reporting data. Unfortunately, the availability of the data as reported from the CDC, from the NIH, and the various other reporting agencies that are governed, that are made available to all of us, but to clinicians it's really important, like Morbidity and Mortality Weekly, and certainly in the professional journals, they're still publishing the data. But a lot of the data that's compiled is being, there's pressure on them for not to disclose all of the data. We also mentioned, incidences where my health issues or friends and family or people who are very near and dear to us have been in catastrophic situations where they've required being in critical care, in an ICU, and going beyond urgent care and emergency care. And that was my specialty. As an internist, I gravitated towards managing, besides many complicated internal medicine cases who had more than one challenging, life-threatening disease process going on simultaneously, but I also dealt with patients who needed to be on a ventilator or needed to have multiple blood transfusions or needed to get TPN, total peripheral nutrition, and then being on many different intravenous medications simultaneously. And with everything that's been happening with our doctors and nurses being, with the numbers being reduced, with relief workers having to go into work under extraordinary circumstances, with being concerned about their own health and well-being working there. The cohesiveness in these medical facilities, in these hospitals, and extended care beyond the hospital situations, I suspect very strongly that the ball gets dropped along the way. So for example, with my critical patients that really needed a nurse standing by the patient 24 hours around the clock, taking blood gases, electrolyte levels, and giving me all of the parameters besides the physical symptoms. They needed physical therapy. They needed to be rotated, temperature, blood pressure, and venous blood gases versus arterial blood gases. We do all of these things, but we really needed a tight team where the principal nurse who was instructing when I wasn't absolutely there, wasn't personally in overseeing the case. I had someone who could anticipate everything based on years of experience of working together, knew that these things, I need to contact Dr. Wallace immediately. This has changed. This vital has changed. Or if this happens, we need to go to this next step. So like urine production going down, or there wasn't physical therapy because there was another critical case in the hospital, those sorts of things. So you have these tight teams that work together so well. So that has been somewhat disrupted with the pandemic, and because of the vaccination mandates and all. So the team cohesiveness and readiness and resiliency because of their own mental and physical well-being and their concern for their loved ones, all of those things are factors involved. There are other factors involved as well. When there's too many cases to manage and you no longer can focus solely on making sure every single I is dotted and every T is crossed, then that person can get stressed, and things that they normally would have been able to do get overlooked, and then the patient's condition can gradually start to deteriorate. Under normal circumstances, an intervention would be done more quickly. Then there's the situation where we have, we no longer have consistency of care. And that starts off in the hospital situation itself. So a patient may come in through the emergency service and say, okay, this is a cardiac case, go to the cardiology unit, or this is an orthopedic case, there's lots of trauma. But patients are multi-systemic, so we have all these different body systems that are involved. And depending on the history, the clinical course of the drainage of the situation, the thoroughness of gathering a whole history, like what medications has this patient been on, what sort of nutritional supplements, how, what their blood pressure typically was. Were they a normal or a low blood pressure? Were they a lower body temperature individual? There's so much data that needs to be acquired. And so this helps the person who's the overseer, the person, the chief of service, if you will, to go ahead and orchestrate things. It's like a conductor of an orchestra, or potentially the coach on the side of the football team. I'm not a sports person. So that person can facilitate and can anticipate what needs to be happening. You know what, we need to get the vascular people in here, or we need to get orthopedics in here, this is coming in, or we need to get the infectious disease people in here. But unfortunately, at this day and age, sometimes things are getting separated and they're getting isolated. So that's one challenge with consistency of care, and there being one chief overseeing things, and then also transferring that when they go off shift, that information to another person that can take over those responsibilities and then retransfer it back to the person when they come back on to the shift. There's also the drop in the ball of consistency. So the person starts to make advances. Their primary situation, like the orthopedic person has done very well with this, or the cardiology service of the cardiac ICU, they've gotten things stabilized as far as they're concerned. And then the person's gradually upgraded in the hospital situation and may do very well, and then goes to rehab or outpatient care or to another service. And the communications need to be absolutely clear: what this patient's been through, what's been going on, what are the things we were worried about, all of those sorts of things. So the ball can get dropped there as well. And this video is not to make things, to point fingers or to over dramatize the situations. I'm going to get to the bottom line in just a moment. I'm going to tell you one of the most valuable things that during my clinical experiences, during my residency and all, was M&M rounds. M&M rounds stands for morbidity and mortality. Mortality is death and morbidity is illness. And M&M rounds is when clinicians come together and we discuss the cases that were in the hospital or that are still in the hospital. A patient may have died and all. And what you have to do as a clinician is you need to check your ego at the door and become humble and listen to all the different advice from all of the different people. The histopathologists, those reports will be in. The clinical cytologist will be there. The neuroanatomist will be there. The clinical neurologist will be there. So you get all of these other disciplines with the experts looking at all the evidence in retrospective and saying, what is it that I could have done differently? What did I do that actually made things actually worse and all? So M&M rounds, you know, it is a tough thing to go through, and it's such a valuable unit. Well, these things, during times like pandemics and all of the other scrutiny especially with our litigious society, with lawyers getting involved and all, these things aren't happening at the levels that they used to happen at when I was there. So this is where we hold ourselves to a higher standard, and we suck it up and we say, what could I have done better? What did I do wrong? And so on and so forth. And these days, these things are changing somewhat. So I've sort of laid out some introduction to this video that I'm going to play that I posted 4 years ago. Things are, I suspect, are much worse as far as how much responsibility we have as clinicians, or I'll say caregivers. And when I say caregivers, I mean at each level of communication and transfer of care and all. So what is the most important thing you can do? Like, one of the things, you know, I would have my clients do is every time I met with them, I asked them to bring a tape recorder in the old days, and then their phones, and record our conversations. Some of the, I would say it both in medical terms and in layman's terms. And that way, you know, they could go home, re-listen to the tape. Nowadays, I'd say videotape everything. And this isn't to put a clinician like myself you know, in defense. It's to help with consistency of care. So when you get home after you've recorded your conversation with a clinician, you know, say my wife's in ICU, this is going on, this is going on. They mention sepsis, they mention SIRS, they mention SIRS, they mention deep vein thrombosis, they worry about pulmonary thromboemboli, disseminated intravascular coagulopathy, all of these things, and the importance of massage care. Well, these acronyms and terms that we use, this day and age, it's relatively easy to use the internet as a tool, and not going on social media things or the different forums, but actually using Google Scholar. Or the other thing is, one of the things Thea and I talked about was the importance of building a social network. Not social media, but actually finding someone who has an interest, and they don't have to have extensive medical training. They may have been a retired nurse or a retired doctor. Having people in your inner circle that can help you to put together a way of breaking down the information. All right, so they're on this medication, this medication, and this medication. How do I find out if there's adverse interactions? Well, you can go online to Hippocrates, and it'll give you a list of not just the adverse reactions and the intended actions, but also the potential adverse interactions between these medications. In this day and age, we're on so many different medications, and doctors, especially when cases get transferred, these things can get messed. And some people are going to different doctors and getting different medications, or taking supplements. And I've talked about some of the herbal medicines and how they can interfere with some of the prescription medications as well in the past. So I guess what I'm trying to convey in this particular video is, it's you and me. We are responsible for our own health and well-being. We need to do everything that we can do. It starts off with a notebook or whatever, and going back to your childhood, vaccinations, your heart rates, every time you got sutures, every time you went to the doctor, calling people up this day and age, and you can get copies of on a USB drive of radiographs or MRIs or CT scans. Having all of this information, this is not for litigation, for suing someone. This is about being able to say, you know what? I think that Dr. So-and-so said to be concerned about this. Bring it up and make sure that we address these issues. And I think it's always important to record the conversations, not for potential litigation. It's for a better understanding. We need to understand as much as we can about our own health and well-being and those caregivers that we're turning over responsibility to. We just don't, I don't think it's wise to just go ahead and turn over complete 100% responsibility and just trust that they're going to do everything possible. This day and age, when you look at the data, we shouldn't do that. So that's as far as I'm going to go with the introduction to this video. What I'm going to do now is show the video that I made in November or February of 2018, I believe it was. I think it was February of 2018. And so pay attention to the end of the video, because you'll see how some of the data that's listed in the first 10 leading causes of death are actually extracted out, and we can find out how that could have been reduced drastically. And I think we'll end this part of the video here, and we'll go into the video now. I hope this is helpful. Feel free to leave comments and questions. I'm not your clinician or your pet's clinician, but what I want to do is encourage you to help yourself, to help. Preventative medicine is so much better than going in there and dealing with it. So doing an oil change in a car is better than having the engine seize up because, oh, nobody checked the oil and the oil was getting burnt. So unfortunately, that happens all too often in our lives. Things that are preventable are not being prevented. Thanks so much for watching, and stay tuned for the rest of the video. Bye-bye now. Hi folks, Kevin here. Well, it's February 18th, 2018, and today I want to talk about the leading causes of death in the United States. What's killing us? And first off, context does matter. Why does it matter? Well, we can't really appreciate an issue or a potential risk until we understand the context of that problem or issue. So why are Americans dying? We're going to go through some graphs from the CDC. We're going to look at what are the odds of dying from various diseases, at least get some scale of reference. And the good news is we can at least prevent or reduce many of the leading causes of death and chronic illness in the United States. So let's review the 15 leading causes of death in 2015, according to the CDC. Number 1 on the list was cardiovascular disease, cancer, lower respiratory disease, accidents, strokes, Alzheimer's disease, diabetes mellitus, influenza and pneumonia, kidney disease, intentional self-harm, septicemia, chronic liver disease and cirrhosis, hypertension, high blood pressure, Parkinson's disease, and pneumonitis. That's an inflammatory condition of the lower respiratory system that's not due to infectious causes. So let's cut that down to just the top 10 reported in 2015. And what's the numbers? 633,000 people died of heart disease. Almost 600,000 people died of cancer. Chronic lower respiratory disease, 155,000. Accidents, 146,000. Strokes, 140,000. Alzheimer's disease, 110,000. Diabetes, 79,000. Influenza and pneumonia, 57,000. Kidney disease, almost 50,000. Suicide, 44,000 cases were reported in 2015. I know I've rounded those numbers off a bit, but at least to give you an idea of how things were ranked in 2015 according to the CDC. So let's look at the number of deaths per day reported in 2015. So 1,736 people died of heart disease in 2015, each day. Cancer, 1,632 people died each day as a result of cancer in 2015. Chronic lower respiratory disease, 424 people died each day in 2015, on average. This is all on average. Unintentional injuries, accidents that cause death, 401 people died per day. Strokes, 384 people died per day. Alzheimer's disease, 302 people died a day. Diabetes, 217 people died a day. Influenza and pneumonia, 156 people died each day. Kidney disease, 136 died each day. And intentional self-harm, suicide, 121 people took their lives each day in 2015. I'm leaving the website references below each one of these slides so that you can review them. What about all homicides, and this is also reported by the CDC. There were 43 homicides per day in the United States in 2015. What about homicides due to firearms? 30 people died due to firearms each day on average in the United States. Now look at this chart. I wanted to bring in terrorism because we are always so concerned. It seems to be one of those big topics on the media, but I wanted to put things in perspective. Context really does matter. So here we are. Now these are terrorist attacks or terrorist incidents. So beginning back in 1995 and ending up here in 2016. So on average, well, basically there were 616 total acts of terrorism over the 21-year period. And that results in 30 terrorist acts per year on average over the last 21 years. Now let's look at another chart. This is from the National Consortium for the Study of Terrorism and Responses to Terrorism, the START program. And I believe this is initiated by the Homeland Defense branch of government. So if we look down this third column here, we can see U.S. fatalities in the United States. In 1995, there were 171 Americans died as a result of terrorist act. And again, in September 11th, 2001, we know that 2,908 U.S. citizens died because of terrorist act. And down here at the bottom of that column, we can see a total over those 19 years with 3,158. That's on average 166 U.S. citizens died per year as a result of terrorist acts. However, that's less than one U.S. citizen dying every 2 days. It doesn't demean the shock and terror of people dying from terrorist acts, not at all. However, when we're doing a risk assessment, I think it's valuable to look at all of these parameters. Here's a risk assessment that's from the United Kingdom. So the big yellow or orangish yellow color here is heart disease, cancer, respiratory disease, and so on, all the way down, and here's terrorism right here. So it's almost like looking at the size of the moon compared to the size of the sun. The greater the risk is, the larger the dot here. Now this was the United Kingdom, and I searched pretty hard trying to get a risk assessment image for the United States. And so this was the National Safety Council there. What are your odds of dying chart. This big yellow dot here, this is heart disease and cancer. This is chronic respiratory disease. This is 1 in, I think it's 191 or 161,000 is the odds of dying from a lightning strike, where your odds are 1 in 7 according to the National Safety Council of dying from heart disease or cancer. So I think it's really wise for us if to really look at the relative risks of injury, death, chronic illness, things that are going to profoundly affect our lives. And certainly if you're involved in in a gun-related incident like has recently been on the news, that is something that really needs to be addressed as well. Terrorism, all things like that need to be addressed. However, I think it's wise for us to look at the leading cause of death that we face in the United States and take those top tier causes and see if we can reduce them as much as possible. So, oops, hold on, there's something missing here. Unfortunately, the way that things are calculated, now, so here we are back with heart disease being 633,000, almost 634,000 cases a year. This is 2015 again. And we see cancer, nearly 600,000 cases a year being caused by cancer. Now, what's this? The doctors. That's interesting. So that skips everything else down, the ones that we cause. So there's some number missing there. Somehow we're going to have to look at how we missed one of the leading causes, the third leading cause in the United States of dying. We missed that particular one. How did we do that? Well, actually, doctors are the third leading cause of death in the United States. Let's see some of the evidence. The website here is down below, and I'm going to play a video now from Dr. Greger, and let's have a listen to that, and then I'll be right back after that.
Yes, an ounce of prevention is worth a pound of cure, but a pound isn't that heavy. Why change our diet and lifestyle? We can just wait and let modern medicine fix us up. Previously, I noted that patients tend to wildly overestimate the ability of cancer screening and drugs like cholesterol-lowering medications to prevent disease, so much so that if patients were told the truth, how little they'd actually benefit, 90% said they wouldn't even bother taking them. The reason we should eat healthier rather than just counting on a medical techno-fix is that the same overconfidence may exist for treatment, too. In a massive study of more than 200,000 trials, they discovered that yes, pills and procedures can certainly help, but genuine, very large effects with extensive support from substantial evidence appear to be rare in medicine, and large benefits for mortality, making people live significantly longer, almost entirely non-existent. Right? We're great for broken bones and curing infections, but for chronic disease, our leading cause of death and disability, modern medicine doesn't have much to offer, and in fact can sometimes do more harm than good. In my Uprooting the Leading Cause of Death talk, I noted that side effects from prescription drugs kill an estimated 100,000 Americans every year, in effect making medical care the sixth leading cause of death in the United States. But that's just for the deaths from taking medications as prescribed. Another 7,000 deaths occur from getting the wrong medication by mistake. 20,000 deaths from other errors in hospitals. Hospitals are dangerous places. An additional 80,000 of us die from hospital-acquired infections, more recently estimated at 99,000 deaths. But can you really blame doctors for these deaths? You can when they don't wash their hands. We've known since the 1840s that the best way to prevent hospital-acquired infections is through hand washing, yet compliance rates among healthcare workers rarely exceeds 50%, and doctors are the worst. Even in a medical intensive care unit, even if you slap up a contact precaution sign signaling particularly high risk, less than a quarter of doctors wash their hands. Many physicians greeted the horrendous mortality data due to medical error with disbelief, and concerned that the information would undermine public trust. But if doctors still won't even wash their hands, how much trust do we deserve? So you could go in for a simple operation and come out with a life-threatening infection, or not come out at all. And 12,000 die from surgeries that were unnecessary in the first place. For those keeping score, that's 225,000 people dead from iatrogenic causes, meaning death by doctor, death by medical care. And that's mostly just for patients in a hospital. In an outpatient setting, adverse effects can send millions to the hospital and result in perhaps 199,000 additional deaths. And this is not including all those just non-fatally injured, like, oops, we accidentally amputated the tip of your penis. And these estimates are on the low end. The Institute of Medicine estimated that deaths from medical errors may kill up to 98,000 Americans. That would bump us up to 284,000 dead. But even if we stick to the lower estimate, the medical profession constitutes the third leading cause of death in the United States. It goes heart disease, cancer, then me. One respondent pointed out that it was misleading to call medicine the third leading cause of death, since many of those we kill also had heart disease or cancer. Doctors aren't out there gunning down healthy people. Only people on medications are killed by medication errors or side effects. Right? You have to be in a hospital to be killed by a hospital error. Exactly. Right? That's why lifestyle medicine is so important, because the most common reasons people are on drugs or in hospitals is for diseases that can be prevented with a healthy diet and lifestyle, as I've covered before. Right? The best way to avoid the adverse effects of medical care is to not get sick in the first place.
Well, I'm back now. I hope that that video presentation by Dr. Greger was of value to you. My hopes were to help to put things in perspective, with the goal of looking at, and this review slide just summarize, in a sense, the things that Dr. Greger just brought up in that video. And I just wanted to highlight those things so you can look at them and see them right in front of you. And my goal here is for us to all become more aware of those things that are potentially going to affect us and our loved ones, those things that are going to cause chronic illness and certainly cause an early death. They're also going to decrease our quality of life, and they add to our expenses. When a family member goes into the hospital as they get older, that puts a burden on everyone else. When we die, it puts a burden on us all. And we certainly all want to enjoy as good a quality life as possible for as long as possible. So I thought it was important to share this information. I don't believe that there was any intentional cover-up as far as not disclosing that doctors are the third leading cause of death. Doctors are not bad. They're not intentionally doing this. They're not just haphazardly going about their days and not paying attention to what they're doing. Our system just isn't set up where we're going to be the most effective. And the first step of this is reducing the number of cases that are having to go to the hospital, the urgent care. It's about focusing on preventative medicine. So I hope this video was somewhat enlightening and helpful. Please subscribe if you haven't subscribed. Give it a thumbs up if you think it was of value. Share it with your friends. And by all means, feel free to leave comments and ask questions. I really appreciate your time and your comments. Thanks so much, and have a great day, folks. Bye-bye now.